Okay, so thank you very much for inviting me down to Seremban to speak. This is a talk I delivered about 5 weeks ago up at IMU Bukit Jalil, and because of the split campus and not many of you could get up there, I get to do it twice. So I'll try to do it better this time than last time. I've learnt from some of the questions that I was asked. Today I'm being a little bit futuristic, so it's a bit of fun, but we have to think in medical education about the future because we tend to train people the way we were trained many years ago for the kind of practice we do now. Whereas I would argue that we are training people who are going to be perhaps practicing medicine quite differently in the future. And I can't predict the future, but what we can do is look at what's happening around us now. So this talk is based upon things that are happening. Nothing I've said here is not possible now, but most medical schools are not doing it. So I'm talking about maybe are we going to look at a different way to deliver a medical program using modern technology, building on the fact that medical practice has many similarities across countries in different parts of the world, and that we're all trying to do very similar things. And there's this concept of globalization and the opposite which may come out. So I also was asked to write about this for Medical Teacher, and it was published last Thursday or Friday. So there is a paper there which is about starting a new medical school, personalised learning. So in this talk I'm taking a view that we are probably soon not going to be dealing with a class of 200 odd faces, but 200 individuals who will each be on a somewhat different learning journey. And that is going to be much more challenging to manage than putting everybody into lecture halls and giving them exactly the same thing. So we'll see how we go. I hope it's interesting. It may all turn out to be complete rubbish. So I say that first. You may next year say, look at that, what that stupid man said. It didn't happen. And that's the risk with futurism, but I'm willing to take the risk. So a little bit about me. Thank you for that kind introduction. I have been coming to IMU on and off for about 15 years in different capacities, so I think I know the system pretty well. In addition, I was part of the GMC from the UK team that accredited Newcastle, Malaysia in Johor, so I do know the Malaysian system a little bit, hardly an expert. I do enjoy Malaysia. I like coming here. What's different about me is that I am a clinician, but my academic training is not in medicine. My PhD was in educational psychology, and at the time I was warned this would ruin my career. But in fact, of course, it made my career, because I sit across two different ways of thinking, and I can move interchangeably, and I often translate jargon and concepts back and forth. And I have found it a wonderful place to be. I love being in new or changing programs. So anything to do with curriculum review or a new medical school, that's where I have probably done best. And for research, I was recently told by the Deputy Vice-Chancellor that I was not a researcher. I have published 200 or 300 research papers in many journals, and I've written many books, and I'm an editor, and I've been on editorial boards, but I'm not a researcher apparently, because I don't research stem cells or neuroscience. But education, medical education and health workforce development is what I've written about, and I'm quite happy with that. Now this is where I'm currently back working. Northwestern Queensland is actually not, this isn't northwest Queensland, there are too many trees. Where I am at the moment is quite dry, and I'm back in very small towns working clinically part-time and academically part-time in a job of mixture of research and teaching. My wife and I are both doing this. She's an academic speech pathologist who does clinical practice in remote areas with students, and I'm an academic doctor who does things in remote areas with medical students and postgraduate specialty registrars in rural family medicine. So as I said, I love new programs, I love innovation, I like thinking differently. What's worked for me as an academic in development, I've been a dean of 4 schools, is a lot of international exchanges for faculty members and students, and I really think we do learn a lot from what we do. I learn more from visiting you than you will learn from me talking to you, okay? And I've enjoyed my accreditation work. I've recently been involved with accrediting 4 schools in China. I've worked in Hong Kong and Thailand and a number of other places, and I feel like I go away quite enriched by observing what other people do. I copy things. I acknowledge, but I copy. You know, there are some wonderful innovations around the world. The best things I find do not happen in Oxford and Harvard. They happen in funny places that have to solve problems that are different. And that's where I see innovation. Something I think I've been good at is engaging students in their learning. And we've just been talking a bit about that in a prior meeting. And certainly one of the ways I've done that is that every medical school I've worked in, I've given 1 or 2 or 3 lectures on how we put the curriculum together, how we assess progress, and how we make decisions about have you passed or not. And they're very well attended, and the students actually enjoy hearing, because they think it's a bit of a magic black box in medical education that we don't ever describe or justify. So I'm going to talk about medical education history and tell us where we are. So I made all this up. None of this really exists formally, but you know, until about Hippocrates, I say that Hippocrates on the island of Kos in Greece ran the first medical school that we have any records of. Before that, it was entirely apprenticeship-based training, because of course medicine has occurred forever. And I acknowledge that this doesn't include cultures like China, which are even older than this, but it's very difficult for me to find much detail of the history of medicine in China. But you know, there has been an interesting development over time where we began as not much better than witch doctors, really, using folklore and mysticism. But what we're doing now is technology, and I've put in this artificial intelligence thing. From about 7 or 8 years ago onwards, we are now getting into much more sophisticated learning support through using technology. Now, whether some of what I say today could be described by fussy people as machine learning rather than artificial intelligence, maybe we'll discuss what the difference is. I think it's just a spectrum. From like case-based learning to problem-based learning, you have machine learning through to artificial intelligence. So you'll be familiar with the picture of apes becoming men, and this is what's happening with technology. We're going from rather primitive machines to things that are going to look and think much more like a human. Is this a scary thought, or is it something we could take advantage of? And particularly in medical education, I see 2 potential areas. That's personalised learning and personalised pastoral care. And I would just like to talk a little bit about both of those. So artificial intelligence in the curriculum. This is a quiz. Which of the following is most correct? So about a curriculum. Who chooses answer 1? Hands up. 2, 3, 4, 3? Okay. So the answer is actually all 4, isn't it? The answer should be 5, all of the above. But that's a really bad way to structure a single best answer question, so I didn't do that. So it could be any of those things depending on what is done. So a curriculum is a very complicated document. It's because it's of its potential misuse or what people do with it. So a curriculum is often a lovely, clear description of what is learnt and is focused on being a junior doctor prepared to do any kind of postgraduate specialty. But the devil is in the detail, and then there's further devils in how you do it. And some of you will have seen some of these slides before. I'm very aware in Malaysia where culture is different to Australia. In Australia, we like knocking authority. We like arguing with people. I wouldn't say we don't respect authority, but people have to deserve respect. It's a very interesting difference. This is a culture where being older, more senior, automatically deserves respect. And I think that that's very interesting when you transpose this to medical education, where students are by definition younger and more junior and no less, and they're put in front of a bunch of senior faculty members who are experienced clinicians with fancy titles like professor. And yet, in the culture I come from, we like the juniors to challenge us. In this culture, that is more difficult to do. When I say challenge, I mean with respect. I don't mean anything rude, but I come from a culture where we believe quite passionately that patients will be cared for better if there is some debate around care, if there is any doubt. And sometimes experienced people, this still happens to me, I learn a lot through being challenged by more junior people. It makes me stop and think. I may go and do some reading around, I may learn something, and that's different to what happens here. The curriculum could look like this. There is a vast amount of information out there which is potentially relevant, and I'm afraid the negative impact of the internet is that while it doesn't look as disorganised as this, there's actually more and more being put up. And also what's important to be aware of now is that the filters are not there. So it used to be that a publishing house wouldn't publish a book unless it was peer reviewed well, and there was some support for the fact that it was evidence-based, accurate. That's all gone now. Anyone can publish their own book. You pay $10 for an ISBN number and some mob in China will print off 1,000 copies for you at very low price. You can go around and sell it yourself on the internet. When I was a dean, I used to get 3 or 4 messages a month from people who had self-published books. Please consider making this a textbook, they'd be saying. And I would always press delete because I didn't know anything about it, but you never know, some of them might succeed. So we are in an age of information overload, an information explosion, and it's difficult to manage. So there are 2 broad approaches, and the first is you control and provide all relevant content to students. The second is you focus on assessment of graduate outcomes agreed by the institution and regulators. Now, I think you'll see that obviously I agree with the second of these. We will never be able to control the vast amount of information that is put in front of ourselves and our students. It's not even worth trying. I think we're getting to the point where we can recommend certain textbooks and journals, but we will have no influence necessarily on whether people will buy them or read them. They will find information themselves, and some of the information out there is very good. So there is a whole bunch of YouTube videos that you should ask your students about, they'll find them, but about all sorts of things. There's Khan Academy TED Talks, which are generally just 20 or 30 minutes, but often by some of the very best speakers in the world on interesting or complicated topics. Why do we insist upon giving our own version of a lecture that somebody has done brilliantly somewhere else? Why not get students to watch it first and come to a discussion around the content? But we do keep giving our own lectures year in, year out, even if they're not very good. So that's just one aspect of where we can probably start to think about working with what is available. So long as students are assessed on the right things, they will learn them. Students are driven by what's in an exam, quite wisely. It's inefficient to learn things that are not in the exam, but they're going to worry about passing. or maybe doing better than passing, and to pass they're going to have assessment passed. So if you write the assessment based upon what students need to know at graduation, the students will learn it regardless of what material you recommend that they read. Now, keep going. This brings us to to technology. So it's not that long ago that everybody had to turn mobile phones off when they entered hospitals. It doesn't seem to happen anymore. I think they were worried that people's pacemakers would stop or that ventilators in ICU would stop. I never actually knew what the problem was, but these days most hospitals are filled with mobile devices, just like everywhere else. It's not that long ago that you couldn't have your mobile phones turned on while the plane was taking off and landing. Now these days, so long as you got it on flight mode, there are people sitting there with their headphones listening to music rather than the emergency system, and it seems to be okay. So technology has been found to be safer, and I think more and more people use it. And the question is, can we use it better? This, of course, can carry far more information than in the entire IMU library. So why do we have libraries? I like libraries because I'm old. There's nothing better, in my view, than holding a book. The smell of a library. I don't want them to be quiet places anymore, and you'll notice that libraries are no longer quiet places, they're coffee shops where people eat their lunch as they watch various media or read various things. But the power of holding an entire library in your pocket on a mobile device is something we should be utilising all the time. So on a ward round, you ask a student a question and nobody can answer it. So you ask, can one look it up? Now, generally not through Wikipedia or Google, but you know, Google will get you started. Why aren't we doing more and more virtual reality? How many people here have had a go with virtual reality? It's kind of scary and fascinating at the same time. Goggles, so you're immersed totally in a 3D environment. So I did this at New York University School of Medicine. They've invested in this. This is quite expensive, so not many places can do it. It's expensive now. I chose a module which was about blood. And I found myself for 10 or 15 minutes sitting on a red corpuscle, going around the body, and I could watch inflammation and infection occurring around me. And this was actually really interesting. So it was factually correct, but I could actually sit there and watch it happening and be part of it all. I narrowly missed being goggled up by a large attacking white cell. So there's all sorts of ways that we can learn. You can go into virtual PBL groups. That software's been around for quite a long time now. Second Life was the program originally. There are now others. So there's all sorts of ways that we can immerse ourselves in a learning environment, but be sitting in a chair at home. Should we be doing more of this? It's still a question rather than something I can answer, but I suspect we will be going this way more and more. It could be possible to have a PBL group when nobody was present in the room together. We were just simply using our devices, but we were seeing each other and interacting as if we were there. You know, it's a little bit like Star Trek, really, isn't it? But there's no reason why we can't do these things even now. So this is what learning used to be like. The learner was at kind of the centre, and there were all these available sources. There's more than I've got here. There were libraries, there were social media, there's all sorts of news platforms and television stations, and we've got our digital devices, and the faculty give lectures and tutorials and take us on ward rounds and clinic sessions, etc. The learning management system of the institution does coordinate a lot of this stuff and put it there when we access it. So that kind of started changing to the point, where all of this stuff goes through devices to the learner. So the learner starts using the device as a filter and a repository and a coordinator and an organiser of the information. And what's going to happen soon is that this is AI, where some kind of a computerised system will receive all the information and then will inform our devices to inform us about what we need to do. So if you could just imagine a medical program where students would be feeding information into their robot, their personal learning advisor, their mentor. Sorry, we humans think we're mentors. I'm suggesting that we'll have things that look like that. Now, you might want to put a human face on this because it looks nice. Apparently, humans relate better to a robot that looks like a human compared to one that doesn't. So we might have to do this. But of course, I don't think he looks very nice. He hasn't got much hair either, a bit like me. What's important is that the role this person plays, or this sort of thing, and you can imagine that if this is constantly trolling the internet for things that are relevant to the curriculum where you are at now, and it knows your curriculum, it knows exactly your schedule, it knows the results of your recent formative quizzes, it knows your strengths and weaknesses, and it might pop up every morning and say, "Hi there, Richard, today you're going to be doing such and such. You might want to, before you go on the ward round, look at this video, read this blurb or whatever," and then I might be able to go back and search it for support materials. But what I'm suggesting is that technology is possible now to get in advance of that and to prospectively select things that people need to learn now. This is not actually very new, it's just that none of us do it. As I'll tell you a couple of examples of places that do. So, this slide did not work, but I tried to personalise it there. So the message would be in the morning, "Hi there, I'm E4PO. I know that's a terrible copy of a particular movie, isn't it? He doesn't look anything like C3PO, but he does look human. I'm your personal tutor and I'm here to help you work, blah, blah, blah." Now, there's actually no reason why we can't be doing this very soon on a large scale. So, all it is, quite simply, really, I mean, IT people, and I've got to say I'm not an IT person, I apologise if I'm saying something wrong to an IT nerd here, but basically there's a whole lot of inputs into a black box that come out, and there's a processor in there, and a lot of memory. That's all it is. Anyone here wearing an Apple Watch or a equivalent? Okay. You can have as much as I can have on this at your wrist. Yeah. Just don't go swimming with it. So the power of this technology, at the moment it's used to tell you what your pulse rate is and what your oxygen saturation is, and the time, of course. None of those are particularly helpful, I wouldn't have thought, in practice of medicine, but it could actually be used to prompt learning and to help you learn as well with the right program. So this is a bit more detail. We'd have a bunch of roles. So it's going to store and analyse a lot of information. Now this is going to be backed up. It's probably going to sit in a huge warehouse in the desert somewhere, because that's what all these cloud-based things do. It's going to help identify strengths and weaknesses. It's going to work with you to do that. It'll search widely for relevant materials, notify, suggest other new materials. But this is where you bring in the Facebook element. It's going to connect you to the people you want to be connected to. So this could be your personal group of 3 or 4 other students on a clinical rotation. It could be that you also study with people across different clinical sites, or that you connect with other people in your own personal networks around learning. So you can have that. It can prompt you around assignments and tasks, and you can send messages to faculty members. Some of this would be automated. So for instance, you would argue that, this is a question, I'm not answering it, but if E4PO here is aware that you're actually not progressing terribly well, should it automatically let a real human mentor know? So I would argue that each student would have a computerised mentor. It would be the same one for lots of students, but there'd have to be a human there somewhere in order to be notified and trigger support. Not everybody will want that because of privacy concerns. It would be completely adjustable for things like privacy settings, although I'm a bit of a cynic. I'm not too sure that privacy settings on Facebook work. You could choose who's in your own network. You could choose or modify search terms. It could suggest some. And you might want to choose your own name for your personal tutor, and you might want to choose what it looks like. And none of that is difficult, is it? Kids are doing that in computer games at home every day. And why are we doing this? Well, it's because I keep showing these sorts of diagrams. So there is a potential curriculum which is huge. There is a kind of an agreed planned curriculum, which is what the medical program says it's going to do. And then that can only be a sample of the potential curriculum. But we can really only ever deliver a sample of the planned curriculum. A lot of it is up to students to learn in their own time with a bit of self-direction. And then we can only ever assess a sample of the delivered curriculum. And this machine, this personal tutor with artificial intelligence, can help align these. That's the plan. It's very important also to remember you've got to be aligned with what the regulators say. So in Malaysia there are two regulators, MQA and MMC. And if you don't do what they want you to do, you're in trouble. You may lose funding or your licence to train people. You've got to make sure that your program outcomes subsume the regulator outcomes. It should go beyond that. It shouldn't be just that. But it should include the minimal requirements to be of graduates working in the Malaysian system. Lack of alignment is bad. Just want to talk a little bit about curriculum mapping, because computers give you the great advantage of being able to do this kind of thing. Now the problem with curriculum mapping is that I've been to many places, seen lots of curriculum maps, and very rarely do they look anything like each other. So I put up a map of Italy just because I like going to Italy, to give you an idea, and there are different provinces in Italy in different states and all that kind of thing. And a curriculum map will list content by timing, sequencing, how it's connected to each other. Sometimes there's a thing called a concept map which overlaps with a curriculum map. The two can be useful. It's important that it comes in different formats, it's accessible to different people. The learning outcomes are layered from high level down to low level, and it's a guide for everybody who's involved, and it should be searchable. This is very difficult to do without the kind of complex computerised system I'm talking about, which is why I think it's going to be helpful for students to know exactly where they are on this map. Now this is a kind of a curriculum map. It's a very high level one. I've made this up entirely. It doesn't reflect your curriculum, but it's a 5-year curriculum with phases and years, and the first year is often the first of a spiral curriculum cycle, and then there's another cycle, and then there's another cycle. So that's a kind of a curriculum map at its very simplest stage, and it helps people understand roughly what they're going to do. And you can see that there's a weighting of domains from 90% science to 10% clinical, which changes by graduation. That's called an overlapping wedge. That's a coloured version of a curriculum map of a kind, but adding a layer of integration. So in this curriculum there are 4 domains, and the proportion of those domains and how they relate to each other varies from year 1 to 2 to 3 to 4 to 5. And these sorts of diagrams again help learners understand what it is they're studying, and this would be reflected in the way the personal tutor system holds information. It would know what stage you are at in a curriculum and be able to help accordingly. That's the overlapping wedges model, where at the beginning you're in the foundation sciences, but there should always be early clinical exposure. And from what I heard today, you're about to increase that at IMU. And right at the end, there should still be some foundation sciences And I think that when students are asked to write up clinical case studies, they should be required to comment on the pathophysiology, the basic science that helps make those decisions and supports diagnostic management plans. That's the spiral. Most medical curricula have 3 spirals, and the learning becomes a little bit more elaborate at each level. So the first one is often the first 6 to 12 months, and the IMU curriculum is the first 6, where there's a kind of a general introduction, a very high level run through, a whole lot of concepts. Then there's a couple of years of going through with integrated into systems-based learning with a higher level of learning required. And then there's the third level, which is generally the clinical years, where you're going through again with that clinical layer of how you apply this with patient care. Now, why I put this up is that my great interest is assessment, and assessment in the first of those cycles can be about largely knowledge, simple knowledge, but by the end it's got to be about how you apply it to clinical practice. So it's very important that there is alignment between teaching and assessment. So here's our personal tutor again. I don't know what name we want to give this guy, but he's there, he or she, could be a girl of course, is there to help. Now, the globalisation part of it. Again, I've worked in accrediting medical schools, or worked in medical schools in Australia, New Zealand, the Western Pacific, Thailand, Malaysia, China, India, Switzerland, England, Ireland, where else? A few other places. And I think we're all teaching our students very similar things everywhere. I don't think there's that much difference. And when people say to me, what is the difference? I say something like, well, my gut feeling is about 80% of all medical curricula I've ever been to are really the same, but there's the bit around it that's different. So what's different is the contextualisation into a particular healthcare system, the cultural aspects of a particular country. Malaysia is a unique country. It does things differently to other countries not too far from here. So, you know, politically, culturally, ethnically, it's different to Thailand, Myanmar, Singapore, Laos, Cambodia, Vietnam. But I'm sure you're teaching 80% of the same material as medical schools in those places are, and you should be. And that means that to some extent your graduates are probably reasonably prepared in terms of knowledge to work anywhere in the world, and yet there are substantial differences in particularly how primary care works, in the communication skills required, and in cultural practices. And they're the bits that are very hard to make the same across different countries. They probably shouldn't be the same. I ask a question because every time we talk about curriculum review, and you're just going through a curriculum review, it's so easy to add stuff, and it's really difficult to manage the content and the density of a curriculum. So I've had a rule wherever I've worked. I welcome innovation, I welcome people wanting to add to the curriculum, but what I've said to them, if you're going to come to a meeting with something to add to the curriculum, I want you to indicate something that you're going to drop from the curriculum. Now that always leads to some fascinating arguments about what's more important, but it is important that you actually don't keep making the curriculum more and more dense. Otherwise the students find it's too hard to learn. There's something called cognitive overload. I don't know if you've ever felt this, but where your head just spins from too much information, and we don't want students to be in that position. So I'm going to give you a real example. At the University of Tasmania, we were conducting a small curriculum review, and I came up with a bright idea, because we kept adding lectures and tutorials, is that we were going to cut the number of lectures and face-to-face contact hours by 20% in years 1 to 3. Now, the first time I said this, this faculty looked at me like I had 5 heads, and they didn't believe it. So I just kept saying it, and we kept having the discussion, and eventually we got there. And this is 3 or 4 slides now on the summary. What we did was we actually managed to cut lectures and tutorials by a substantial amount in years 1, 2 and 3. And then we looked at academic outcomes by using the same exams. And guess what? There was no change. So we removed 20% of the delivered curriculum by tutorials and lectures, and it had no impact on learning. Interesting? This is going to be submitted soon, a paper on this, because people still don't believe it. The percentage of students not successfully completing the year was unchanged. So some said, yeah, the average student will be fine, but the weak ones need more lectures. Well, this is actually suggesting that the weak ones don't need more lectures. And then the final thing is that when we asked students in a survey what they thought of the more compact curriculum, they really liked it. They liked having more time. They used comments like, I used the time to read around the lectures rather than just going to more lectures. Very good comments. So I just use this as encouragement. You don't actually have to fill the students' week up with planned activities. And sometimes students ask for extra lectures, particularly around exam preparation time, but there's no evidence they really help. And sometimes these things become a permanent fixture in the curriculum. And I would argue we shouldn't be adding lectures. We should be taking lectures out and encouraging students to learn in other ways. So there's lots of resources out there in the world, and of course in the clinical years the best way to learn is to see patients, not to sit reading a book or to sit in a lecture room. Okay, we're going to go to Pastoral Care, just briefly. This is a bit harder, and what I've chosen here is a cute robot. If you're going to go into Pastoral Care, you have a cute one. Wouldn't you like to be able to talk to this guy? Okay. I'm R4D4, your personal mentor. I'm here to help you stay healthy so you can enjoy the course. Tell me anything and I'll keep it confidential, unless I think your health is a serious risk. So what that last bit is referring to is that there is an obligation on the system. If somebody sounds like they're about to commit suicide, you know, the system must do something to intervene. But short of that, it's not going to do that. It's a confidential service which is separate from other record systems. So once again, just in the diagram, at the moment the learner has access to all sorts of information coming in from many different sources, and what we'd be doing here is having all of this go into the black box, which may have a face and a name that you choose, and back to the learner via various mobile devices. And what you put in here, it really depends upon what you want to put in here. So as I was telling somebody yesterday, I've recently been involved with a medical school accreditation in China, and for the first time I have seen a system which does the following. All students and all staff have one of these, and every time they go into a lecture room or the library, in or out, they swipe. And the university knows where nearly 100% of their students and faculty are whenever they're on campus, every moment of the day. So I was shown a computer screen which said, just at the moment, this is a Year 2 class, and all but 8 are in the lecture room. Very high attendance rate, because if they miss more than 3 lectures, they're thrown out of university, which is a bit harsh in Australia. One was in the university shop, they could tell, because he or she had bought something there 5 minutes ago. One was still asleep in his or her bedroom, or at least in the bedroom, because he was currently online in a computer and could tell that it was on the internet. And a couple were off campus and therefore they didn't know where they were, so they were going to go looking for them. Now, I think this is a bit scary, and I just want to say in advance, I don't propose that that needs to be part of this system, but it could be. And what this robot system would do is be very helpful around trying to predict patterns of behaviour that might be worrying and suggest resources. So mental health is one area where apps have shown real progress. So there is cognitive behaviour therapy apps, there's all sorts of apps around mental health, and you could imagine that student wellbeing could be enhanced by this little robot that looks cute, suggesting various healthy activities, exercise, stress relief, meditation, mindfulness, CBT apps, etc., and would know whether you're well or not from what the email behaviour is, what your family and friends on the social networks are saying, and it'll know what your results are. Kind of scary, but it's all possible now. So, roles, again, apparently computers can monitor moods. Do you know this? Who's on Facebook? Anyone? It monitors your mood. It apparently has an algorithm where it decides that you're sounding a bit unhappy. It also looks at your preferences for shopping. As you walk past McDonald's in New York, it'll say, "Did you buy anything from McDonald's in New York? How was it?" I hate those things because I never go into McDonald's. I may walk past them. So if you're connected, where you are is known by a computer everywhere in the world. So I say this stuff really exists already. It's a question of can we make it helpful in medical education. So how you connect this, there's going to be some adjustable settings for it. But I see real promise, because one of the problems we find in Australia is that students don't want to talk to faculty members sometimes about personal problems. And they fear that if they tell a faculty member that they're depressed or unhappy or not too sure they want to do medicine, it might impact upon their exam performance or their choice of specialty training later. So if I've unloaded to somebody that I'm very mixed up, I'm not too sure I really want to be a doctor, and then 3 years later I'm being interviewed to enter physician training and the same person walks in the room. So some of these are real concerns, although I'm not too sure that would happen. So maybe this current generation in medical schools, they're on devices all the time, they talk to computers all the time, they already tell it way too much. You know, that's why Facebook knows so much about us. Maybe this system will work, or a system like this. Now, this is a question about, should our personal tutor and personal mentor be the same computer, or should it be two computers that are connected somehow? And again, I don't have an answer for this, but in my thinking they're separate and they don't communicate except in extreme circumstances. Okay? So the answer is no. So I guess in summary, this has been a little bit of a walk through, a bit of futurism. I'm not too sure what artificial intelligence is going to bring, but I'm hoping that the experts who say the following are right. That is, what they're saying is that artificial intelligence will not replace jobs where complex judgments are required. So I think that's us. I think we make complex judgments on multiple sources of information that are often conflicting. And this is the sort of thing that the computer experts think artificial intelligence will do the least well. So it may fly us to the moon and back, but it can't probably work out whether somebody might have this particular diagnosis or not, or whether this management plan will work. It will certainly help. Already in oncology, there are very strong computer-based algorithms for choosing drugs, and that's good. But for many things, it's just somehow this sixth sense that humans with experience get. So I don't think we need to worry that AI is going to destroy our jobs and our careers. It may have the potential to add value to learning and pastoral care support systems We need to be in there helping the designers of this. One of the things that I think medical education does poorly is help technology work for us. So we often react to technology development rather than prospectively saying, well, if you can do that, could you do this? This would be more helpful for us. So things like Facebook develop and get a life of their own and do wonderful things in social media, but in fact, to do this in medical education in the way I've discussed might be more valuable. Probably be very expensive and all that kind of thing. Now, there are a couple of models around where things like this I've come across in my travels are getting close to it, so it's, let's say this is not necessarily too far away into the future. Unlikely to replace us, because I think we will still be needed as teachers as well as clinicians. I think it's also going to improve or address or streamline with globalisation, because I think more and more and more students are going to be studying the same curriculum for at least the 80%. And there's no reason why these networks of students can't be across medical schools, within countries and across countries. Why can't we have PBL groups in different countries learning about common topics? The technology is not far away. I now regularly support learners over Skype. Now that's old technology, it's nothing new, but I've done it to remote Australia from Kuala Lumpur, this visit. So I'm not out of touch with learners who depend upon me for support. I can be there whenever they want me to be there by pressing the Skype button. Okay, so I think that was about it. Just finally to say, there are no security men in the room, are there? But security robots are apparently the most likely to take over the industry. Okay? So if you know anyone who's a security man or woman, their jobs are more under threat than ours. Because these guys look scary, you can never stir them up and get them angry. They can't punch you because they're not allowed. Unless, has anyone seen all those wonderful movies about robots with the first, second, third and fourth laws? Any science fiction fans here? All this is in the movies, it really is. I learn about this from watching science fiction movies. Anyway, that's where we're going. So we could have a totally automated police force in robot cars before we'll have robotic doctors. Thanks very much. Any questions?